Hello friends. Topic of my video is one of the most common infection nowadays, that is respiratory syncytial virus. I'm going to say RSV whenever I'm talking about this infection. But the motive of this topic is not just talk about what the condition is caused by RSV, but there are multiple aspects of this condition infection. One of them is how do we treat it? How can we investigate it? What are the things we have to remember as a red flags? So few things which I'm going to highlight is these ones. So let's start our video. Most common cause of respiratory infection in infants and in young children. This is about Canada as well as North America too. It usually causes upper respiratory tract infections, but may be progress to lower respiratory infections that can lead to pneumonia and bronchiolitis. Usually a child comes to us in a clinic who is less than 2 years old, who comes with the upper respiratory tract infection. It is possibility he or she is having being exposed to RSV. But if condition is getting worse and worse, then they might go into the lower respiratory tract and cause the infection of pneumonia, and one of the most common is bronchiolitis. What are the risk factors for a patient who gets a severe RSV infections? These are only those who are high risk children. What does that means to high risk children? That means premature infants, less than 35 years week gestational age delivered babies, young infant with having any chronic heart or lung conditions like cystic fibrosis, asthma, congenital heart conditions, immunodeficient infants, Down syndrome, any neuromuscular disorders, because if they have a neuromuscular disease, they are not able to uh, having a proper functioning of their lungs and of their smooth muscles, so that can lead to the RSV infection more severe. So these are the risk factors in which a chances of getting a severe RSV is very common. But if a child is normal, he does not have any of these situations, they might get a less severe upper respiratory infection because of RSV. What is the peak incidence for severe illness? As we are mentioning, like it takes up to 2 years for a child to get this, but if child has been exposed within 2 to 3 months of his age, the chances of getting severe infections are very high. This is the peak age for the getting a severe illness because of RSV. Usually chest x-ray, any type of viral testings are not recommended in RSV. RSV is basically clinically diagnosed case. Evidence does not support, yes, evidence does not support using bronchodilator, epinephrines, corticosteroid to treat RSV infections. So, if a patient is coming to us with RSV, he has a breathing difficulty, he has nasal congestion, fever, we do not give corticosteroid, epinephrines, or bronchodilators. These are not giving a good benefit to the child. One more point which I wanted to highlight, basically two more. One is the ribavirin. Ribavirin is a medication. When we are using it, we are only using it to treat very high risk cases. That means patient is immunocompromised and they come up with severe acute RSV disease. So make sure to highlight the word and. It is not talking about or. Ribavirin cannot be given to a child who is severely ill because of RSV. It is only given when a child is immunocompromised and they come to us with a severe acute RSV disease, or maybe a conditions like lung problems, maybe a premature infant, maybe something. So in this cases we give our ribavirin. Immune prophylaxis with palivizumab is recommended for high risk infant during RSV season. So that means you see the word why I put the high risk list in the starting, because everything talks about uh, high risk later in the page. So if a child is high risk, come with severe acute RSV disease, we can give ribavirin. If a child is high risk, RSV season is going on, we might give immune prophylaxis, that is uh, this pelvizibam. Okay, there is no vaccination to prevent RSV. We have to remember RSV can be treatable, can be prophylactically given, but it is not having any vaccination which we can give it to the kids to having a prevention from RSV. What are the differential diagnosis of RSV infection? For example, child is coming to us, the name of the condition and having an infection. So one infection is RSV. What type of condition we might diagnose or we might label? Asthma, bronchiolitis, influenza, pneumonia, croup. These are all the list of differential diagnosis. Now, our main target for this topic is bronchiolitis. Let's talk about what is bronchiolitis. Bronchiolitis is basically lower respiratory tract infection. It is an inflammatory condition which causing the small airway obstruction, causing it to progress into pneumonia, apnea, respiratory failure, might be death. So bronchiolitis is coming to the lower respiratory tract infection. 80% causes of the bronchiolitis are due to RSV. So if we have RSV, don't forget to look for bronchiolitis symptoms and signs, because RSV can cause 80% of the bronchiolitis. One thing which I want you guys to remember is RSV is also a leading cause of viral middle ear infection in young infants. That means middle ear infection can be caused by RSV. What is the source of infection or transmission? Person to person through respiratory droplets, or maybe secretion which contains virus, like if we sneeze, there are some secretions on the tables, on the hands, and that contain virus, and from person to person it can be transmitted. Number 2 is direct skin contact. Number 3 is contact from contaminated fomites. That means tables, chairs, any surface which is already contaminated, doorknobs, elevator buttons, anything. COVID-19 can be transmitted via aerosol transmission, but RSV is not transmitted via aerosol transmission. That means it can only be transmitted via respiratory droplets and contacts on the surfaces and where the virus is present. So aerosol transmission is common in COVID-19, but it is not common in RSV. Let's talk about sign and symptoms. What are the sign and symptoms of a person who comes with RSV infections, have bronchiolitis or something? They can come have fever, malaise, nasal congestion. Why? Because of hypersecretions of the mucus and they are not able to take it out. Rhinorrhea, runny nose, sneezing, difficulty in breastfeeding if a child is breastfeeding because of the nasal congestion. They might have cough, sore throat. Now, let's come down with the severe symptoms. Decreased oxygen level, that means less than 90% because of alveoli is being collapsed into because of this infection, because RSV is lower respiratory also, and air is being trapped and the exchange of air with the blood is not happening, so that's why oxygen level is decreasing. Child might be coming with tachypnea, the breathing rate go up to more than 70. Hyperinflation of the chest. If the child is asthmatic, like a school age child, they will be having acute exacerbation of asthma. Lower chest wall and drawing is also seen in severe cases. On auscultations, what type of things we can listen? Wheeze, bronchi, prolonged expiration, or fine crackles. Some children with less than 2 years old can come with the RSV and the auscultation, we can listen expiratory wheezes and inspiratory crackles, or we call the crepitations. Let's talk about normal child, no high risk patients when they have RSV infections. Child less than 2 years commonly infected. Male child, in vitro tobacco exposure infants. If child is born as a twins or triplets, chances of getting infection is very common. Young maternal age, lack of breastfeeding, because breastfeeding is a protective factor for these types of infections. Lower educational levels of parents, lower socioeconomic level, start living in a crowded area. School age siblings, they go to school, their siblings are going to school, coming back with the infection, and that is being caught by the little siblings who are less than 2 years old. Secondhand smoking exposed. Winter seasons, if I talk about specifically Canada, then I would say it's October, November till April, May. This is the period where RSV is very common. What are the treatment options? Normal child come with RSV infections, they have nasal congestions, they have a little bit of fever, they are not able to breastfeed, but they are keep having well hydrated. We give a supportive treatment, which is the mainstay of our treatment in a child. What is the supportive treatment? What types of supportive treatment? Suctioning with the nasal bulb syringe of their secretions in the nose, and we use normal saline drops to clear the nose and they can have a good breathing. If child is having severe infections, that means oxygen level is lowered down. They are having intercostal indrawing. They are coming with the high grade fever. They are dehydrated, not passing the urine output as normal. So in that scenario, you have to hospitalize the child. You have to give oxygen supplement if the oxygen is less than 90% and child is tachypneic, that is around more than 70 breaths per minute. And if it's dehydrated, that means you need to give IV fluids. You can give normal 0.9% normal saline as well, or 5% dextrose. So these are the treatment options which we give. Usually our main target is supportive. If we are giving supportive treatments, then we always tell the mother or father that you have to look for any red flags. You have to look after your child in a way that keep monitoring their symptoms. If it's getting worse, you need to come to the hospital as soon as possible. Okay, so I have taken a little chart which is very beautiful because it gives an idea that in which conditions we can say that our bronchiolitis condition in a child with the RSV infection is having mild symptoms, moderate symptoms, severe symptoms, and how can we manage those severity. General behavior in a mild patient is he will be normal, alert, active. Respiratory rate could be mildly elevated, but that's okay. If it's less than 2 months, if it's 60 per breaths per minute or more, if it's more than 2 months and 50, that's still be mildly elevated. Nasal flares or grunting is not present. Use of any accessory muscles is really minimum or none. Oxygen saturation is good, that is more than 92%. There is no apnea. Apnea is important if you are talking about severity of bronchiolitis. Feeding would be normal, slightly decreased because of the nasal congestion. We will managing at home. We have to deliberately follow up with the doctor. We need to make sure that there is no deterioration, specifically for high risk infants. Now let's come to the moderate type of severity. Moderate means child is alert, but at the same time irritable and able to be consoled by mother or by parents. Respiratory rate going to be increased but not very much high. You remember we talk about more than 70, that is a severe case. So in the moderate it could be more than 60. Nasal flaring or grunting very less or absent. Use of necessary muscles, moderate child chest wall tractions. Oxygen saturation might go down but not less than 90. That means they doesn't need any oxygen supplementation most of the time. Apnea, Here, in moderate situation, apnea may be brief and it is a self-limiting episode. Feeding would be decreased but will be able to take it more than 50%. That means in moderate it's more than 50%. How you can manage? Likely we have to admit the patient. Give oxygen to maintain the saturation for more than 92 via nasal cannula or mask. Our main target is giving oxygen supplement to just maintain their more than 92%. That means giving a oxygen saturation level up to normal. Administrating maybe NG or IV hydrations because they are not able to take feeding properly. Observe closely for any deteriorations. Still they are in moderate situations, they are good to go. We can just observe and do a light admission, likely admission to the hospital. Let's talk about severe cases, which is our red flag situation. We cannot miss or avoid any symptoms in the severity. Increasing irritability, difficulty to control, and lethargic, or child may be fatigued, tired, drowsy. His respiratory rate is more than 70. Nasal flaring is present. Chest wall indrawing or retractions, that is very severe. We call intercostal space indrawing. Oxygen saturation is less than 90. 100% oxygen supplementation should be given. Increasing frequently of your apnea and prolonged episodes of apnea. Significantly decrease intake of less than 50% of normal feed. Required admission to hospital, possibly in ICU. Give oxygen supplementation to maintain oxygen saturation. Continuous observing and maybe need for CPAP. NG tube or IV dehydration is important. High risk infants and young children may require hospitalization even with mild symptoms because they might get worse. They might not be managed properly at home because of they are very high risk infants. Apnea can lead to death, maybe the only symptoms in less than 1 month. So that's the only reason we are trying to admit the child who are very young and even with the mild symptoms. Immune prophylaxis, as I mentioned you before, we have to give some immune prophylaxis, but there are some specific criteria. Premature infants less than 30 weeks born and are in the RSV season of less than 6-month child. That means premature less than 6 months in a RSV season. Congenital heart condition less than 12-month infant. Chronic lung condition less than 24 months infant. So this is all about RSV as well as bronchiolitis. So never give epinephrine, corticosteroids, any bronchodilator, but you have to check for mild symptoms. Manage at home if possible. Red flags. What are the red flags we have to tell to the mother to be seeing? Nasal flaring, feeding decreased, apnea, muscles, accessory muscles are being used, child is being lethargic, drowsy, and the respiratory rate is increasing. These are all the symptoms which we have to monitor while managing a patient for mild or moderate. Thank you so much for listening to this topic. I hope you like it. If you have any feedback, I'm more than happy to see. Thank you so much and have a great day.